Live? Okay. All right, everyone. Thanks for joining us on this nice chilly Wednesday evening. Bob Sershon with Anderson Clinic. This is just the beginning of a series that the clinic's going to be doing every third Wednesday of the month, just going over different things in orthopedic surgery. I'm a joint surgeon, so I'm going to talk about joint replacements today. And everyone here in the clinic is specialized, fellowship trained, has something that they expect. We'll have them talk about their topics and go from there. So this is going to be, from my standpoint, pretty informal. I want everyone to learn about outpatient joint replacement, really the biggest thing that we're doing right now. And from there, I'll bring up some slides and we'll be able to kind of track as we go. So save your questions. There should be a messaging board for people to put in comments and things like that. And we'll address those as best we can at the end. And that's it. So we'll get going here. Let me bring up these slides. Good. All right. So hopefully everyone could see this and we'll get going. So outpatient hip and knee replacement technology and techniques. Disclosures, we always have to give disclosures for any talk that we give, at least in our industry. And it's really important for people to know, I'm an owner at surgery centers. I think this is a huge plus for us as surgeons. We get a lot of control this way over what happens at the centers in terms of staffing, what equipment we use, what the staff we have, the anesthesia group that we use, when we can come and do surgery, how many patients we could have. There's just a lot of things that really make it more conducive for us to have a better day and quality of life. So, and then I do some consulting for industry that's not pertinent here. So, about me, I actually finished my training there at Rush 9 years. And then for my fellowship, which is just an extra specialized training, came out here to Anderson Clinic and stayed. So that was back in 2019. It doesn't seem that long ago, but here we are. At this point, I'm doing about 150 joint replacements a year. That was last year. That's, to my knowledge, the most in the DC area. 600 of those were outpatient replacements. So people that went home the same day. Of the 250 that were done at the hospital, about 100 of those were revision surgeries. So complex referral surgeries that are sent in that, I think Anderson Clinic has built a name for over the decades for people to help bail them out of difficult situations. We do a ton of research here. I do a lot of research with our research institute, and we'll kind of highlight some of our papers and show the knowledge that we've gained through outpatient surgery. And then I also do some implant development with companies, and a few of our other surgeons here have actually developed kind of world-leading hip replacement and knee replacement implants. So I think with any talk, and we'll get over to the next slide here, it's important to know, the overall global why. And this why on here, this is not just for me. I think this is for Anderson Clinic as a whole. So I think you guys are on this talk maybe because you want to be better. Maybe you have a bad joint in some way or the other. Our clinic, just overall, is to make people better. I mean, that's the most simple way to put it. We do our best to have a patient-centered experience. We're always doing innovative techniques. I mean, this is what I think separates us from the rest, and then doing a lot of research. The what replacements, but we have great guys doing foot and ankle surgery, hand, shoulder, you name it, spine. So the what is just what each of us do, but the why is why we're all connected in the clinic. So this is great. It's grown 35-fold in 5, which is absolutely crazy. This is near and dear to my heart. I trained at Rush, which was the place where outpatient joint replacements were. This was back in the early 2000s. We were over there, and it was met with a lot of resistance for decades, even. And eventually it became something that was commonplace, but for me, that was always commonplace. And so now, our practice does about 75-80% for most of the surgeons outpatient surgery. And so we know that it's safe to perform and optimize patients. So people that have heart failure, people that have kidney failure, have liver disease, things like that, as long as they're optimized and they're as good as they're going to be, and their primary care and their specialists think it's safe for them to have surgery, it's likely safe for them to go home. And we'll get into situations where we would probably choose not to bring someone to the surgery center, but for the most part, most people can go home same day. And so on we go to the studies that we've actually done. These are all from our institution. So you'll probably see my name on there, Bob Sershon, and then Bill Hamilton, Kevin Fricka, the three of us kind of leading the way here in terms of outpatient surgery. And we've looked at partial knees, full knees, and full hip replacements. Very large cohorts in the thousands at this point, looking at safety at outpatient surgery. Because if you're going to adopt something, you need to make sure you're doing it in a safe manner. We're dealing with people here. These are not just cars coming in and out. So for us, it's very important to not have readmissions, transfers to the hospital. Same. I've had just 2 of those over 5 years. Patients, fortunately doing well, and both of them actually having a surgery even after that on a different joint, not the same one. So that's something that we are very keen to avoid, and something that I think through our protocols and through our experience has made it exceptionally safe to do. So by the time people have seen me, they've mostly tried everything, right? I'm usually not the person they're coming saying, "Hey, I've had 2 weeks of knee pain." This is usually someone that's been struggling this for a little while, either their hip or their knee. They've either tried anti-inflammatories or steroids, therapy. All types of non-operative treatment are available for people. But once you get to bone on bone, a lot of the times that's just not going to work, and that's not going to cut it. So people want improved function. They want a better quality of life. And, they're probably willing to deal with maybe some of the new superpowers that they're going to get, like going through metal detectors and other things that MRI restrictions that come with the territory of a joint replacement. But when it is time, this is what the joint replacements will look like. Okay. So on the far left here, you're seeing a hip replacement. This is the most modern replacement that we have. There's triple taper stems that we call them, and it's just a ball and socket joint. That's it. So we're taking out the ball, we're putting in a new ball and socket. It's a very simplistic model and simple joint. Actually, patients do exceptionally well after this, and we'll get into the kind of the techniques and technologies that we use to help expedite recovery for this. In terms of total knee replacements, I look at it as putting a new roof on the house, right? So, roof's 30, 40 years old. You need new shingles, and you go ahead and take those off and put on a new one. It's not like you're tearing down the entire house or you're tearing down the whole second floor, or if you have a ranch first floor. You're just giving it a new layer on top, almost a resurfacing, if you will. And then partial knees are something that most of the joint replacement surgeons in our clinic perform a lot of. And this is basically a new tire. Okay, so you got 10,000 miles on the tires, you run over a nail and you blow a tire. You're usually not going to replace all 4 tires, right? You're just going to replace the one that's blown, and the other 3 are going to function completely fine. And so that's how we look at partial knee replacements. There's a certain selection criteria. It's a bit more nuanced than that, but that's just a general way that I want people to look at this. So anterior hips, right? I think this is one of the biggest things that people have caught on to, just because patients do so well with these and the success rate is so high. So I personally like to perform them because, one, they're muscle sparing, right? So there's been plenty of studies showing that patients in the early postoperative period, we're talking the first 4 weeks to 4 months, have less pain and a faster recovery than the other approaches. The outcomes are excellent. So in my practice, it's lower than a 1% revision rate over 5 years. We used to quote people, this is even back when I was, training 10 years ago, a revision rate of 1% per year. That's what we used to tell people. It's just not that anymore. It's much lower than that. And this is not just me. I would tell you this is across our clinic. All of our hip and knee replacement surgeons have exceptionally low revision rates. It's also great to do the anterior because there's no strict hip precautions. So the dislocation rate is inherently low for the approach. It's under 0.5%. So we don't tell people, you got to get a raised toilet seat, or you can't cross your legs, or you can't bend past 90 degrees, or you can't do this. There's not a lot of can'ts in the early postoperative period. which really facilitates people getting up and going home early, right? Because that's what we're talking about. It's a low fracture risk. And then for me personally, the accuracy of the implant placement is just better than for posterior lateral approaches. You can use all types of technology. You can use computer navigation, you can use AI, you can use augmented reality. I've used all of them. They're all great. They're all tools. And ultimately you as the surgeon have to put things where they should be. But these are all things that are great check reins, and they can really show you, hey, I have, 42 and 20 degrees or whatever your targets are on your hip. And then they could tell you how long your legs are, how much offset, so how wide the hip is. These are things that can tell you with high accuracy. We're talking 1 to 2 millimeters of accuracy. It does take more planning. It's a little bit more of a cost burden, but I think that it's well worth it. So one of the unique things that I'm doing right now, and I'm not sure anyone else in the area is doing this, are bikini incisions. These are twofold. So I would tell you that the first reason to do it is for wound healing. So when you do incisions that are, and hopefully my mouse works here to show you, longitudinal, these go across the lines of tension on the skin. Okay. When you do it horizontal, we'll call it that way, sideways, it goes along with the lines of tension on the skin. So what ends up happening is there's just less stress, less pulling on the skin. You're less likely to get skin breakdown. So this is a patient that we're just showing here that has a well-healed traditional incision on the left. That's a good-looking incision in my opinion. I think that healed very well, about as good as they can. And on the right's a bikini. I mean, you can barely see it, and this is not best case example. I mean, this is fairly routine for what we're seeing on our patients. Some patients, it might be a little bit darker, a little bit, a little bit wider, but for the most part, that's what they look like. And again, it's to prevent wound healing complications. The cosmesis of it is secondary. I originally started doing this for, believe it or not, super morbidly obese patients, BMIs 40, 50, getting really high up there because I was worried about patients having any type of wound breakdown. So I got to move a little bit to get the lights on. There it goes. So all right. Okay. So knee replacements, right? So these are things that I think people associate with the toughest recovery, and I think that that's true. We are getting much better, even over the past 5 years. I think there's been tremendous leaps in the realm of knee replacements. So the type of knee replacement I do, it's called kinematic knee replacement. I wouldn't say that it's new. It's been around for 15 years, but I think it's really caught on fire recently. Patients just, at least in the early recovery period, appear to do better. And so there's about 20 randomized trials at this point comparing traditional techniques, mechanical alignment, gap balancing, versus what we call kinematic, which is just a way to resurface the joint, if you will. So I'm not going to get too much into the alignment philosophy and things along those lines because it's very nuanced, and even some orthopedic surgeons have a hard time grasping this. But the whole point of it is that you want to do all of your corrections through bony cuts. You don't want to release all the ligaments or tendons or muscles or anything like that if you don't have to. So in the past 2 years, I've not done a additional single ligament release during surgery, even in severe deformities like I'm showing you up on the screen here of someone who was severely bow-legged. And, we were able just through bony cuts to restore his pre-arthritic joint, right? Because that's the whole point. We want to get you back to the pre-arthritic state of the joint. And in my hands, I switched over to this over 2 years ago. I'm not going back. My patients in my practice have done much better with this technique. And I think that, others in our practice as well as outside are also adopting this technique. And again, because you're not releasing soft tissues as much, that theoretically should result in less pain, early mobilization, getting people home the same day of surgery. With hopefully a lower narcotic burden, pain med burden. So robotic knee replacement. So this is a love-hate relationship for me. I think that people come in thinking that the robotic part makes it a completely unique, separate surgery as opposed to a normal knee replacement. It's different. Yes, it's more accurate. I think the data would tell you that, we have objective measures that we could put up on a screen, but it's still the surgeon doing the surgery. It's still standard components that we would use if we weren't using the robot. The robot is just a tool to execute your surgeon's plan. And so I want to make that very clear for people, because I think a lot of people come in thinking, oh, I'm going to have a robot do it. Yeah, a robot will be there, but I'm doing it. I'm the one that's going to be doing the surgery if we're using the robot, which we don't use in all cases. So I think that the benefits of the robot are about the same as the benefits of the kinematic knee technique. The whole idea behind it is to balance the ligaments and get the pre-arthritic joint without tissue releases. And so if we are doing that, okay, yeah. And so if we are doing that, we would hope that the patient's able to get up and walk around and have more stability in the knee with less pain early on, so that they're able to go home the same day. There's a bunch of ways and different tests that you can get to do these robotic cases. So a lot of the times it could generate a 3D model like you're seeing in the bottom left. It could generate a 3D model during surgery. Some systems need a CT. Some systems you can use an MRI. There's no one single way to do it. So that's it on the robotic knees. Again, just remember, that's a tool. It's ultimately your surgeon who's going to be doing the surgery and making the calls on the alignment of the implant positioning. In terms of partial knee replacement, I mean, this is something that I love. I think that, at least Kevin Fricka at our shop has really championed this through the past 20 years of his career. But it's something that patients come in and they have arthritis in one place in their joint. So I have the nice red arrow there pointing where, you would see bone on bone, but it's just in one place. This patient probably has great range of motion. They won't have arthritis under their kneecap. They have pain only on the inner side of the knee. Maybe they're a little bit more active. So these patients, we believe, are better candidates for a partial knee replacement. And a partial knee replacement should not be looked at as a stepping stone to a replacement. This is not a, hey, we're going to do a partial knee replacement and come back in 5 to 10 years and do a full. That's a failure. That should not happen. That's what I tell all of my patients. If I, within my career, am operating on you again on the same knee that we did on a partial, that was a failure. That shouldn't happen. So we're very particular about who we pick, the indications, and the technique of how you put it in, because partial knees technically are actually more difficult surgery to do than a full. There's a lot more that can go wrong in terms of not doing it right and having an earlier failure than you would have in a total knee. So even though it's a smaller surgery that we actually as surgeons get paid less for, which is probably appropriate, it's something that has higher risk, if you will, for failure. But the outcomes in our hands, we believe, are better than full knee replacement. So if my knee looked like this, I would rather have a partial knee than a full knee. There's no question. And I would go to a surgeon who is going to offer a partial knee to me. The one thing about partial knees that's great is that they're outpatient for pretty much everybody. Medicare actually mandates that it's an outpatient only procedure. But I really believe, because it's so minimally invasive and it's such a quick surgery, in my hands, it's about 20 minutes. We can get people up, walking around, and home the same day. So let's get to that. So what does it look like when you're getting an outpatient replacement? I mean, from start to finish, this is the overview. We'll get into some of this in a little bit more detail, but I don't want to drone on for you guys. We'll get to some questions. So one, it starts with the in-office education. I've made booklets for my patients that they've all read. They're about 20 minutes, and we have those as well for the others. There's preoperative optimization that we do. So we have this drink that we have people take that we think is helpful. In terms of pain management afterwards, we have a variety of drugs that we give people. Usually it's just Tylenol and anti-inflammatory, Tramadol, which is Schedule 4, a little bit lower level of a narcotic. And then you have your actual narcotics for people who need them that, for a lot of these patients, they just don't require them. Early ambulation is key in the outpatient setting. And most people from foot in to foot out, it's about 5 to 6 hours. At the surgery center, home same day, and then they can start their therapies. So Pre-op, we're going to have some communication 7 to 10 days prior. This is really your final clearance in my mind. So Annie's my PA. She sees all of my patients, or I should say our patients, preoperatively 7 to 10 days prior to surgery, just to go over, okay, are their labs really good? Are they appropriate for surgery? Has the primary care and cardiologist given the input? And then kind of goes over the process for surgery. So this is something that I think has been great for us in terms of patient understanding and education leading into their surgery. And then the day prior, they'll call you and they'll let you know, hey, here's when you show up, have your, what we call a joints coach, but the person giving you a ride that's going to be able to go over discharge instructions with you, because we don't trust you're going to remember it. You just had anesthesia. And they'll give you all other information right before surgery. So the goals for the day of surgery, I mean, they're pretty simple, the goals. Achieving them can be difficult, but now I think we've really dialed it in. So pain control is number one, early mobility, hydration. If people are hydrated, they're less nauseous. They don't have as much dizziness. For the men, they don't have urinary retention where they're not able to pee after surgery. It can be an issue. We don't want any plan confusion. So this is one of the reasons we have one of these visits 7 to 10 days prior to go over this, and why we have the preoperative education in the office. People should know what's happening and what's going on when they go home. And then most importantly, we want people to get home safely. I mean, that's number one on the list for us. This is just a chart to show all the things that go into planning for your pain control. And then one of the things you'll notice here is there is not much in the way of narcotics, right? So we do a lot of things. And the only thing we have down here is, some fentanyl or oxy as needed in the PACU immediately after surgery for when the spinal wears off. That's the only time that people get it in our hands. And a lot of people don't need it. So it's one of those things where this is very well thought out, and we've really helped with the help of our anesthesiologist, have helped hone this in over time. In the recovery room, what does that look like for you? Well, the anesthesia wears off. You're groggy. We want you up, eating, drinking, taking your meds. As soon as you can start feeling your legs start to move them, and then the nurse is going to come by, get you to stand, walk, do some stairs. It's 4 or 5 stairs. It's not onerous. Everyone does it. Use the bathroom and go home, right? Once you get home, this is the most pivotal thing. The first 10 days of your recovery, especially after a knee replacement, you need to be icing and elevating for 40 minutes every single hour of the day. At night, I tell my patients, put the ice machine on, go to bed. When you wake up, fill the ice machine up again and put it back on and go back to sleep. It's a swelling game, knee replacements are. And so if you can control swelling, you're going to control pain, you're going to get your range of motion back earlier, and you're going to get back to what you want to do earlier. I limit my patients so much the first week. I want them doing less than 500 steps a day if they can. It's really good for you to not be doing much and taking care of the inflammatory cascade. After that first 7 to 10 days, and if you're doing well and you show up to therapy and you've got great range of motion, they're going to be impressed with you. You're going to come back at the 4-week visit, maybe taking Tylenol, some anti-inflammatories. Very, very rarely do we have anyone on pain meds still at the 4-week visit. And, most people by that time are ready to start ramping up into more activities. So the getting home and elevating and icing really facilitates, from an outpatient standpoint, facilitates recovery. And, so what does that look like? So at 4 weeks, most people walking without a cane, Tylenol or anti-inflammatories only. Knees, we want over 115 degrees of bend, and hips, they're usually walking about or able to walk about a mile a day. By the 4-month mark, we have no activity restrictions, right? So people can continue their conditioning and follow up with us as needed. And we're able to do all this by sending people home the same day, right? Why not do it for everyone? Not possible for everyone. I mean, we have people with severe congestive heart that need to be monitored afterwards, or they're on home oxygen, or they're on a kidney transplant list. They need dialysis. I mean, you're talking about very sick people with a lot of comorbidities. And some people, you can tell they just don't understand the process. They're confused. Maybe they don't have social support. They've, in my mind, failed the look test. Just something doesn't look right. And I don't want to take them to the surgery center. I think they're better off in a hospital setting with a little extra attention, and that's great. So So that's it. So, we can conclude outpatient is safe, it's growing, it's the preferred method for patients. And at this point, technology is just a bunch of tools that we use to help improve the surgery, recovery, and things are constantly on the horizon. So that's really the talk. We got some questions that were thrown in, so I'm going to jump into this right now. So one of the first ones is, what are the risks and benefits of minimally invasive techniques? Depends on if you're talking about a hip or a knee replacement. If it's a hip replacement, I think we highlighted these during the talk from the anterior, the hip standpoint. You're not violating any muscles, right? And it's intramuscular plane. It's a faster recovery. I mean, that's been documented and studied over and over again. On the knee side, also a mid-vastus technique or something that's a quad tendon sparing technique. You'll achieve earlier quad activation, so you'll be able to get a straight leg raise a little bit quicker. Theoretically, you'll have some less pain early on, and maybe some better range of motion early on. But by 1 year out, regardless of technique, the minimally invasive benefit goes away. I mean, we've seen that time and time again, either a hip or knee standpoint. So I think the minimally invasive benefits are really just for early on. I mean, the risks on the hip side, I at this point, it's more risky for me to do a posterior hip replacement than it is an anterior. So I don't really have risks on the hip side for minimally invasive, but on the knee side, I suppose if you're converting from traditional approach where you have a foot long incision, your visualization is likely not going to be what you were accustomed to. So you might be at higher risk for some type of soft tissue injury. But that's about all that I can really, muster up. Minimally invasive at this point, incisions aren't big for most surgeons anymore. So it's all over the place in terms of what that definition is. Factors the choice of the surgical technique. If maybe they mean surgical approach. On the hip side, I do anterior approach for everybody, all comers. Very, very rarely will I do a posterior hip approach at this point. We had one a couple months ago that I had to do for a patient with severe hip dysplasia, and actually brought in Andy Yang, one of my partners, to do that with me. That was really fun. And she's doing great. We're about to see her in a couple of weeks, actually. So for a 4-month follow-up. So that's surgical technique. For me, it's just all anterior for all patients because we do so many. We're so comfortable with it. On the knee side, that's just dealer's choice. I think it's whatever the surgeon's comfortable with. I do a mid-vastus quad technique on everyone. I believe Kevin Fricka does the same. And I can't speak for the other guys in the practice. I just can't remember off the top of my head what they do. Specific concerns related to bone quality or joint condition that might affect the choice of implant. Yes. So on the knee side specifically, and I didn't get into this in the talk because it's about outpatient, not the actual implant technology. But on the knee side, you have two choices globally. One is a cemented knee replacement, which is what the traditional knee replacement that everyone, I think, thinks about. And then you have a cementless knee replacement. So these are newer fixation surfaces for the implant. And what happens is it acts just like a hip implant where you have no cement, you have a coating on the back that's usually some type of porous metal that the body wants to grow into, mostly titanium. And what happens is if you have appropriate bone quality, the body can grow into the implant. The benefit of that is that we feel it'll never come loose. Once you achieve implants, we feel stay forever. It doesn't mean you won't wear out the plastic. It just means that the implants won't come loose, whereas cement is grout, right? So cement can come loose over time. Now, that's not something that's going to happen usually 5, 10, 15 years down the road. Usually if cement comes loose in a well-done knee replacement, you're looking at 20, 25 years down the road. I'm still seeing some of Dr. Jerry's patients that come in, they're 30 years out from a replacement that's functioning completely fine. Maybe they need a new piece of plastic. But poor bone quality that's likely cement. So that does affect it on the knee side. On the hip side, we are an institution is very heavy on cement less. Charles Eng, one of the original cementless hip replacements, was actually made by him. He's one of the designers. So we've been very heavy on not using cement for hip replacements at our institution. However, there are patients that have such poor bone quality that it may behoove them to get a cemented hip replacement as well. Those are rare. They're less than 1% in our registry. And that's where the knees may be over time. In my practice, I'm about 90% no cement on the knees as well. So, and the next one, how do you know if you're a candidate for outpatient surgery? I mean, that's going to be up to your surgeon. I mean, for me, you have a 90% chance that you're going to be. There'd have to be a real good reason that I need to bring you to the hospital. It's nothing against the hospital. I mean, we partner with Inova. I think they're a great partner. They have been for 30 years. I just love the autonomy of the surgery center. I have my same team every time. Anything that I want to do in terms of implant choice, case order, the amount of cases, the timing of the cases, it's just more nimble for me. And the patients just prefer it, quite honestly. They like going home the same day. So that's what we do. And so next question is, tell us about robotic knee surgery. And what about the Jiffy knee? Pros and cons. Again, robotic knee surgery, robotics are a tool. So if I have a certain angle that I want to cut your proximal tibia, your two bones in your knee, I can do that within, without even using the robot, within a 1/2 degree of accuracy, using my normal jigs. With the robot, you're still within a 1/2 degree of accuracy. I do such high volume that, and as do most of my partners, that we're not dependent upon the robot. I mean, we do just as well with our hands. The robot just provides you with more objective data during surgery to help you confirm that you've achieved your plan. That's all that the robot does. It's not a special or different surgery. In terms of the Jiffy knee, I know some about this. All it is a subvastus technique. I mean, there's nothing special about it. It's still a standard knee replacement. It's a quad bearing knee replacement, just like we do. The incision's a little long. But I know the surgeon very well, and I can't comment. It is just local and possibly marketing, but patients are doing well with it. Good on the surgeon for making the technique and for people doing well. Do we have a therapy group or therapist post-operatively that we work with? I mean, I'm biased. I mean, we have our own therapists at Anderson Clinic, so I would trust any of our therapists to work with our patients. That is nice. That is a perk from a therapy standpoint. Because if there's a problem, they just walk into clinic and tell us. We have people, Stacy, doing that for us when I'm in Mount Vernon all the time. Hey, there's something I want you to come check out, or I have a question about so-and-so. It's pretty easy to do that. There's great places around here with Jackson Clinic, Select, all these other groups as well. But our therapists, I mean, that's where I try to send people. If people live a ways away, like I have a ton of patients from Winchester, Southern Maryland, Manassas. I don't want you driving this far to do therapy. That's not good for your recovery. So do it somewhere local. We have an app called Force that does walk people through their post-operative recovery. So it will give you exercises. So my hip replacements, for example, actually all of the joint replacement guys, our hip replacements do not normally. We do it all in the app. I've also my partial knee replacements, formal therapy, do all the therapy on the app. It's not that the therapist can't do it, completely necessary with the techniques that we're using. Full knee replacements are a different story. But just using the app, I mean, clearly patients do well. And those are things that we've vetted and pick the exercises and give the protocols and have okayed all of this with Force. It's been a good company to work with. Does age have any detriment to what type of knee surgery? Oh, sorry. Determinant. Okay. Well, detriments. No. Yeah. But age number. I talk to patients about this all the time. It's not that I don't care about age, but I look at your global health. Okay. There are plenty of people in their late 80s that I've operated on that are healthier than I have patients who are in their 50s and 60s. They're on no medications. They're living independently. They have a great life, and the worst problem in their life is their knee or their hip. We do replacements on these people. I've done outpatient on patients in their 90s. They've gone home the same day. Again, this is someone who's completely with it from a cognitive standpoint. They're in good health. They have social support, and they want to go home the same day. So age is a factor to some extent because as everyone, you lose muscle mass, you get worse coordination, balance. Anesthesia tends to affect people a little bit more. So we want to be cognizant of that. Those are patients, once you get in your mid to late 80s or older, you might want to be in a hospital setting, still with the option to go home the same day. But patients in their early 80s that are doing well, I mean, we just did 1 or 2 today from Harborside Surgery Center and sent people home. So that's my thought on age. And then the type of knee replacement, no. I mean, you might be more likely to get a cemented than a cementless. It depends on what ligaments you have in the knee. So the ACL is a ligament that is taken out with essentially every knee replacement. There's one knee design that one surgeon uses in the group that I give a hard time to that lets you keep the ACL, but it's rare that you're able to do that. So the ACL is taken out in every knee replacement. So if you're saying you don't do any tendon release, or sorry, any ligament release, you're theoretically taking the ACL. I try to keep the PCL in all of mine. That's the posterior cruciate ligament. You do have the option to take those, and the majority of people actually do take that. I think it has functions there for a reason, so you should keep it. In terms of tendons, the robotic surgery doesn't change your approach. So you can do a parapatellar approach, which is it goes into the quad tendon, and that's the most common approach that people do. I don't do that. I do a mid-vastus, so I don't get into the tendon at all. But that has nothing to do with the robot. So this is a good question, because these are the type of questions that people need clarified. The robot has nothing to do with this whatsoever. It's probably less likely that you would do or need a ligament release if you're tight on one side of the joint rather than the other, because the robot can tell you, hey, your balance is not perfect here. And you can do some cuts through the bones to change that. But the robot actually has no role in whether or not your surgeon decides if you need a tendon release or a ligament release or something like that. So, good. Wrap it up. Yeah. All right. Well, that was all the questions. We're about 40 minutes now, so I think that's enough time. Thank you, everyone, for your time this evening, and stay tuned for the next talk that I think is Dr. Sheff, correct? Yeah. Yeah. So I'll be talking about some shoulders next month. Thank you, everyone, and take care. Good night.